Hi, I'm Larry Dean. I'm the director of the UW-Madison Regional Heart Center in Seattle and a past president of SCAI. And it's a pleasure to be with you to discuss a recently released document, an AUC on multimodality appropriate use criteria for the detection and risk assessment of stable ischemic heart disease. I was a member of the technical panel involved in the development of this particular document. I think the importance of this document is that it's the first document that's been produced in an AUC format that really looks at various modalities that can be used in the assessment of patients with stable ischemic heart disease or those who may be at risk for that disease. This particular document, as is common in AUC, has clinical scenarios. In this document, there are 80 different scenarios. And I think when you look at a document like this or another AUC, as has been discussed in the past, that these 80 clinical scenarios are by no means representative of the entirety of patients and their presentations. But nonetheless, they're fairly common clinical scenarios. And the thing that's unique about this document is rather than looking at just the clinical scenarios, we're also looking at various modalities that can be used to either make the diagnosis of ischemic heart disease or to assess patients who have either prior history of ischemic heart disease or at high risk for potentially having the disease. And this particular document's looked at, again, these 80 clinical scenarios, but has looked at various modalities, including stress electrocardiography, stress radionucleide imaging, stress echocardiography, stress cardiac magnetic resonance imaging, and coronary calcium scoring, coronary CTA, and then invasive coronary angiography. And through these 80 different scenarios, these various modalities are ranked in the usual fashion as either appropriate, maybe appropriate, or rarely appropriate. That's the new terminology that's used in the AUC. From the standpoint of the takeaway for the interventional cardiologist, I think there are a couple. One is invasive coronary angiography is appropriate in many clinical scenarios, in particular patients who have, for example, a very high risk or very obvious symptoms of ischemic heart disease. An example being a 65-year-old gentleman with typical angina who has a high risk or high pretest likelihood of the disease. Coronary angiography in that particular scenario is considered appropriate. I think the other place that the interventional cardiologist can look in this document is the whole issue of pre-operative assessment of patients undergoing non-cardiovascular surgery. It's a nice summary of that area, basically pointing out unless the risk is quite high or the patient has unstable symptoms, that in many cases, if it's low risk, no imaging or no modality is considered appropriate. But if it's a higher risk patient, obviously, clinical judgment may have to be brought to bear. But nonetheless, it's another part of the document I think bears your attention. With that, I think I'd recommend that you go and take a good look at this document. And it was a pleasure bringing this to you this morning. Thank you.